Hello, I'm Dr. Kelly Hunt. I'm a breast surgeon at the MD Anderson Cancer Center, and I'm here today to talk about the lymph node management for women with breast cancer. This is a really important topic, and things have been evolving over the last several years because of many clinical trials that have now matured and are being reported, and we're trying to incorporate these new trial data into our practice. So historically, the lymph nodes have been part of the surgical resection of a patient with breast cancer, largely for staging, but for patients with more advanced disease, it's been part of also regional control and potentially improvement in survival. Now, early data from NSABP B04, which is one of the first clinical trials done looking at the management of the regional nodes in patients with breast cancer, we know that data from that trial showed there was no difference in survival outcomes in women who presented with clinically negative lymph nodes, whether they had immediate surgery with lymph node dissection or whether they had a delayed lymph node dissection at the time of clinical presentation of nodal metastasis. So from that data, it was suggested that really the only information provided by lymph node dissection was staging information. But this question has persisted, and as things have changed over the last couple of decades in terms of greater understanding of the molecular subtyping of breast cancer and the biologic underpinnings of breast cancer, it's now come to question again whether we need information about lymph nodes or not. So first, just to talk about sentinel lymph node surgery. Sentinel lymph node surgery has emerged as a very useful tool for breast cancer staging. It's useful in women who present with early stage breast cancer where there's no clinically evident disease in the regional nodes. And what we can do is identify the sentinel node as that first node that drains from the primary tumor to the regional nodal basin, most often the axilla. We can remove the sentinel node, and then that is a reflection of the regional nodal basin. So if the sentinel node is negative, then there's really no need to dissect additional lymph nodes because you're removing a lot of healthy nodes that are not going to impact the outcome for the patient. If the sentinel node is positive, then that suggests that the patient may benefit from additional treatment. So the sentinel node trials that have been done over the last couple of decades have tried to answer the question, is it safe to do sentinel node alone versus axillary node dissection in terms of overall survival, disease-free survival, and local regional recurrence? And the NSABP B32 trial and also the Milan trial that was published by Veronesi and his colleagues have shown that there are no differences in survival rates or local regional recurrence rates in patients with early stage breast cancer who undergo sentinel lymph node dissection alone compared with those who undergo axillary lymph node dissection. What is different is the morbidity. So the axillary lymph node dissection is associated with much more morbidity, lymphedema, paresthesias in the arm from interruption of the intercostal brachial nerves, and also shoulder immobility and other problems after that type of extensive surgery. Sentinel lymph node dissection has much lower rates of these types of morbidities, and so overall improves quality of life for our patients. So I think it's pretty clear in early stage breast cancer patients that sentinel lymph node dissection is a better way of staging the regional nodes as compared with axillary lymph node dissection. But it does require training. The surgeon does have to learn how to do the procedure, and there are certain principles that we've learned, such as the number of sentinel nodes recovered is important. So most often in breast cancer, there's more than one sentinel node. There's usually 2 or 3 lymph nodes because of the rich lymphatic drainage of the breast. And so it's important that the surgeon recovers all of the sentinel nodes in order to have accurate staging. There's also a higher rate of false negative events, so that means that the sentinel node is negative, but some of the axillary nodes are positive if the patient's had a previous excisional biopsy. And so there are factors that do influence the accuracy of the technique, and it's important that the surgeon is accurate in their technique. As we've gained more experience with sentinel lymph node surgery, and the pathologists are now receiving fewer lymph nodes, so 2 or 3 nodes as opposed to 15 to 20 nodes that they would get in an axillary lymph node dissection, they're starting to do more detailed assessment of those nodes using immunohistochemistry and more thorough sectioning through the nodes. So they're recovering these very small foci of disease, sometimes even just isolated tumor cells or micrometastases. And the question is, when you get a node like that, recovered from a sentinel node dissection, do you really need to do additional surgery? Does that patient need an axillary lymph node dissection? And so that was really the focus of the ACOSOG Z11 trial, where patients with early stage breast cancer who had a positive sentinel node were randomized to have axillary node dissection or no further axillary surgery. And they would complete their treatment with whole breast radiation. These are all patients having breast conservation, and get systemic therapy based on the primary tumor factors. So what this trial showed was that there was no difference in overall survival or local regional recurrence in the treatment arms, whether the patient had a completion node dissection or not. So this has been a real change maker in terms of our clinical practice. I think and certainly in the U.S. and across many countries worldwide, people are now incorporating this into their clinical practice. And it seems to be most relevant for those patients who have small tumors, T1 to T2 tumors, who are having breast conservation and whole breast radiation. And, that is really the parameters of the Z11 entry criteria. There have been some trials looking at this same question in patients undergoing mastectomy, for instance, the IBCSG 2301 trial that was just completed recently and published. And that one did include patients who had mastectomy and micrometastases and did not show any difference in overall survival or local regional recurrence in those patients who had a completion node dissection versus those who did not. So there's emerging data that maybe even in mastectomy patients, we do not need to do a completion node dissection. What has really changed over the years is our use of systemic therapy. So we've really, more and more of these patients are receiving chemotherapy, endocrine therapy, or a combination of these therapies. And we know that that impacts local recurrence, also impacts regional recurrence. And in fact, these systemic therapies can eradicate nodal disease in patients who present with node-positive disease. So the other area that's really changing quite a bit now in the field is how do we manage these patients who present with node-positive disease? We biopsy the node, we prove it's node-positive, they get systemic therapy, neoadjuvant chemotherapy, and then they appear to be clinically node-negative afterward. How do we manage these patients? Well, sentinel node surgery has been explored in this setting, and early studies suggested that it was not very accurate. And part of that was because there were no specific surgical standards for how to do sentinel node in these patient populations. And also because they were small studies, single institution, no standard pathologic assessments, no standard surgical procedures. And so the data suggested that the false negative rates were too high. So the ACOSOG Z1071 trial, which was just published in 2013, was actually exploring sentinel node surgery in patients who have node-positive disease, get neoadjuvant chemotherapy, and then appear to be clinically node-negative after chemotherapy. Is it accurate in that setting if we have standards for surgical procedures, if we have standards for pathologic assessment? So what that trial found was that in the patients who were clinically node-positive at presentation, who appeared to be clinically node negative afterward and had at least 2 sentinel nodes recovered, that the false negative rate was about 12.6%. So that's still a little bit too high for us to be very comfortable with sentinel node surgery as a staging tool after chemotherapy in these patients. But what we found is looking at different subsets of patients, if there were 3 or more sentinel nodes recovered, the false negative rate was lower. And also, if there was a clip placed in the sentinel node, in the node that was positive at the initial diagnosis, and then that clipped node was recovered as part of the sentinel node dissection, the false negative rate was substantially lower, somewhere around 6 to 7%. So actually, by paying attention to certain standards, surgical standards, we can actually really improve the false negative rate in this patient population. So there is now an interest in doing what's called targeted axillary dissection, where basically when patients present with node-positive disease, that lymph node that's positive on biopsy gets clipped, and then at the time of surgery after chemotherapy, we pay attention to removing all of the sentinel nodes and also the clipped node, because the clipped node is not always one of the sentinel nodes. And that improves the accuracy of the technique. We can get pathologic information that we need that might help us in terms of prognosis and defining radiation treatment fields in these patients. And so overall, it gives us a lot more accurate information. I think the key is that we're trying to reduce the amount of axillary surgery, because now that we understand more about the molecular underpinnings of breast cancer, we don't need to do as extensive surgical procedures. We need to do targeted procedures that help to remove the tumor that might be residual, to remove any lymph nodes that might be important in terms of determining radiation treatment fields or other things. But we don't need to be removing a lot of healthy tissue that leads to significant morbidity and can impact quality of life. So this is where the field is really moving. I think it's a very exciting time, and I think it's great for our patients. So I'm very excited about this, and I hope to see targeted axillary dissection coming to the forefront very soon. Thank you.